The next speaker, my dear friend, Dr. Kazutoshi Hida, is with us. He's a very active member of Japanese Neurospinal Society. He's the past president of that society, and he's now the director of Sapporo Azabu Neurosurgical Hospital. And he will talk about the treatment considerations in cervical OPLL. Yes, Professor Hida, we are eager to listen you.
Thank you very much, Professor Zileli, for your kind introduction. And thank you, Professor Kuroda, and thank you, Professor Fujimura, to give me a chance to talk my experience in this meeting. Today's my topic is treatment consideration in cervical OPLL. There is no conflict of interest in this presentation. Just I'd like to show this the slide. Professor Zileli, do you remember? Just 11 years ago, we have an international meeting in Sapporo. Dr. Mizuno and I are co-chairman, co-director, and you, Dr. Zileli, come to Sapporo. And Michael Failing, Koyanagi, Professor Yoon, and Hirosabe was there. Today's, before talking about today's topic, in Japan, we have many elderly patients. And actually, I can say Japan is almost the longest lived country in the world. Therefore, we have so many degeneration disorder in patients. Actually, this you can see that as for cervical degeneration disorder, there is a lot of a spectrum from the OPL to soft disc herniation. And OPL is the most toughest, I think, disorder to treat. And OPL and the pathogenesis is still unknown. Multi-factor is involved, we guess. There is no geographic difference in its prevalence. However, in Orientals, Japan, Taiwan, and Korea, so we have a lot of patients compared to non-Orientals. This is a famous and simple classification of cervical OPL by Professor Hirabayashi, a KO orthopedist guy. And he classified a segmental and continuous type, and mixed type, and other type. I like this simple classification. And the development of neurological deficit, and there is two factors. One is the static factors, and just spinal canal stenosis and associated hypertrophy of the PLL or OIL. The other is dynamic factors, that is instability. But actually, compared to usual spondylosis, OPLL has not so unstable. And protrusive disc adjacent to OPL is also dynamic factors. This is very important information about the myelopathy of the OPL. And in this slide, open circle means the absence of a myelopathy. And closed circle means a patient with myelopathy. When spinal canal is less than 6 meters, all cases showed myelopathy. However, when spinal canal is between 6 and 40 meters, higher range of motion patient showed myelopathy. And you can see in this patient, you can see the OPL in the segmental type, but the most narrow portion is not OPL itself, but disc protrusion between OPL. This is the paper about disc protrusion and OPL. And Dr. Koyanagi, my friend, and Dr. Hanakita just reported in segmental type, you can see the higher percentage of disc protrusion, and mixed type just in the half, and continuous type just much less percentage protrude disc level. And this slide shows surgical selection with a cervical OPL. And in OPL patient, there is in an asymptomatic patient, we should not treat them. And a symptomatic patient and the resist for the conservative treatment is a patient we should treat. And localized OPL within 2 corpectomy, we should do the anterior fusion. In a patient with extensive OPL or narrow spinal canal or association of the OPL OIL, we should do the laminoplasty or laminectomy. And as for the concept of the selection of the surgery, this is a new concept. Now, not so new, but that's a good right idea of the selection of the cases. In the K-line. K-line is a name of Dr. Konish's K, I think. And they just published is a K-line idea. And K-line minus means such a like a kyphotic patient, and K-line plus, plus is just preserving the lordotic patient. And the mean recovery with the rate was K-line minus patient is very not good, and K-line plus is much better surgical result. And ultrasonography showed the posterior shift of the spinal cord was insufficient in the K-line minus group. In even they did post-laminoplasty. So I'd like to mention about the anterior approach, and we just show this slide shows a corpectomy. I think corpectomy should be wide enough. That is much safer. So therefore, the range of 23 or 25 wide is a good, I think, wide width. And we should be careful not to damage the venous plexus itself. Once venous plexus is break, that is very tough. And be careful for the CS leakage. And so recently, just ultrasonography device is very highly useful. This shows the microanatomy is a PLL, posterior longitudinal ligament. That is my late Dr. Kubo. That's published in a neurosurgery. It's a long time ago. But at that time, Charles Tata mentioned this paper, all neurosurgeons should read it. And as for the PLL, there is 2 layers. One is a deep layer, just locates not deep in a ventral. And the other is a superficial layer. That is just actually dorsal. Because that's, I think, deep layer of superficial is not good name, but long time ago, Japanese orthopedists named it. They did because laminectomy. So ventral layer and the dorsal layer much I think should be we rename it. Anyway, superficial layer of the PL joins the dura mater as a lateral portion of the dura mater, and this is a internal vertebral plexus, and anterior internal vertebral plexus is narrow in a disc level, but wide in vertebral body level. Therefore, surgery of the corpectomy in a cervical OPL is sometimes tough for the bleeding of the internal vertebral plexus. And this venous plexus exists inter-PLL space itself. Okay. And the OPLL often shows a double layer. That means both deep layer on the superficial layer is ossified. And sometimes dermata itself is ossified. So before surgery, just doing the bone window CT, we can know that is this case has a higher chance of CSF leakage or not. And the type of dural ossification, Dr. Mizuno just classified just in a simple cases, types 1, 2, 3. And the anterior fusion, this is a long time ago. We did just using the iliac bone itself. That's actually once we did surgery, that was operative X-ray is pretty nice, but actually there is often patients complains pain or sometimes iliac bone fracture and meningeal parasthesia and the infection too. And so, and this is Professor Wang's report, and among 249 cases for the 25 years old follow-up, and you can see one level displaced graft case is 4%, or 2 level 5%, or 3 level 9%, and 4 level 16%. Therefore, longer bone graft can bring a higher percentage graft displacement. This is after iliac bone and anterior ACP, anterior cervical plate. And this is after corpectomy. That's now, so using the mesh cage and 1 level corpectomy and 1.5 corpectomy is safer, I think. And this is a OPL patient in a double, showing the double layer. So just using the mesh cage and the SCP. There's another case just compressed very much. And this also, but this is actually, it's a tough surgery. And later, I think just I use the height adjustable titanium cage like this one. And that's actually, in this case, maybe laminoplasty might be better. But anyway, localized C6 level, high compression. And so just to do the anterior fusion this way. This shows 45-year-old woman showing the right dominant theta paralysis. And this that's use the height adjustable one. He showed a nice result after surgery. But later, actually, 3 years later, she showed just neck pain. So, can you see? See? Yes, just this device was broken. So, I did a posterior fusion. So, any device could be broken. I think simple is best. So just nowadays, standalone damage in this way. So actually compared with the cervical spondylosis, OPLL is not, I think, it has instability so much. So just put the mesh cage damage, that is enough, I think. And this is just cases. At first, I start from the up and post lower part of the just treating the spondylosis. I didn't start from the corpectomy because not to decompress root itself is very important. after that, just doing the corpectomy. Sorry, this portion I always use a drill, but I think this video may be used for the propaganda of the ultrasonic device. So sorry, but anyway, this portion, the OPLL itself, I use as an ultrasonic device, just in this way. This after surgery. In such destruction with other devices also is nice. And such a just for the only spondylosis patient on the device, in such a not so severe one, just one level corpectomy plus ACDL. Such a combination is, I think, safe and this in good way. And in this one, just in this way. And to prevent CS leakage is a important issue. So using the PJC fascia and fibrin glue to make this space minimize, and the spine dredge once happened for 2 days, for 5 days. And they're using the polyglyceride acid PGFL and plus fibrin glue. This is I did experimental study before, and even just 2 millimeter 2 millimeter width of the fibrin glue that is has a good enough power to sealing. But I think just prevention of CS leakage is much more important. Actually, after moving to my hospital, for these 11 years, I never have the CS leakage because I did such a microfloating method itself. Just don't remove all OPL, just make OPL to paper thin. That is, I think, much safer way. Just I'd like to show as a posterior approach briefly. Laminoplasty, as you know, there are many kinds of laminoplasty method. And our way is laminoplasty bilateral decompression in this way. This is after surgery, but preservation of the paravertebral ligament and muscle is Dr. Kim or Dr. Shiroshi mentioned to minimize surgical insult and postoperative pain is important. Just keeping the muscle intact. And another device is a double door laminoplasty with suture anchors. Just is such a way, just anchoring way. And in this way, I use this laminoplasty method for the mainly spinal cord tumor, not spondylosis. And the titanium spacer is also popular in Japan, and like this way. And so in such a OPL, just in this way, or even OPL develop, it is okay. And another in unilateral or bilateral way, so use. And this cervical OPL patient, just using this device in this way. And the laminoplasty posterior decompression is actually universal way, but it is not 100% safe. This patient is after decompression in other institution, he showed neck pain and myopathy. And you can see the extension way. This shows, that soft herniation was observed. And this is a recent way. The 54-old man, he showed a severe neck pain and right C5 palsy and crampness of the right hand. He underwent a laminectomy 2 years before in other institute. Actually, so after that, the orthopedist referred to my institute to surgery because he showed at the C3 and 4, 5 level, and it's a remarkable compression of the spinal cord in the right side. And you can see the big massive OPLL in the right dominant. So I did anterior decompression fusion in this way. He's still doing the rehabilitation. And this is as for the complication of the cervical patient. And this is the review of the 27 studies with a total 1,500. And the complication rate itself is very high, 21%. Actually, I just was amazing. CSF leakage is 5.1%, implant failure 3.5%, hoarseness, dyspnea, and dysphagia were common in anterior approach. And C5 nerve palsy and axial pain were more common with posterior approach. I think even I have the C5 nerve palsy, and I just, before the surgery, I just explained to the patient, even anterior or posterior cervical operators compared with the cervical spondylosis in a little bit higher percentage C5 nerve palsy. And this is a take-home message. In cervical opera, anterior approach is preferred for localized opera within 1.5. I said two vertebral segment, and now I think 1.5 vertebral segment is corpectomy. And longer, I use hybrid corpectomy is high HDF or not. And to prevent CS leakage, microfloating method is very highly useful. And once CSF leakage occurred, using the favoring group plus PGSC is highly useful. Anyway, just minimize the dead space is very important. And more extensive opera, not only posterior approach, but hybrid anterior fusion corpectomy plus HDF is safer and useful surgery. Thank you very much for your attention. Thank you, everybody.
Thank you, Dr. Hida. It was great talk, as usual. Actually, this topic is it has been in the historical, has been a topic of Japanese spine surgeons. First ortho spine surgeons, then neurospine surgeons. But there are still some issues like complication rates. Do you think that if you are thinking there is a dural adhesions of the OPLL that you avoid anterior surgery? Dr. Mizuno's paper is telling this actually. He was telling that a certain amount of patients may be guessed before surgery with the CT scan, very thin CT scans. What do you think?
Yes, that is before surgery, just bone wind CT is my paper, and just double layer shows high percentage of the dura mater ossification itself. And so in that cases, we should be very careful for the CSF leakage. But actually, and CSF leakage, even we avoid just using the spine drainage, it may bring, as you mentioned, the adhesion around the spinal cord. So therefore, just not to bring CS leakage is very important, I think. And
What about, yeah.
Yeah.
Okay. Continue, please. What about the Chinese surgeons has described ACAF, a kind of anterior replacement of the vertebral bodies 2-3 levels by making grooves on both sides anteriorly without direct decompression, just indirect decompression and pulling the OPLL ventrally. What do you think about that technique?
I think I've seen that presentation, but if OPL itself is as long as its OPL itself is not big, that is I think maybe they can. But broad OPL or tough one is very I think high potential of high risk of spinal cord damage, I think.
Okay.
Professor Zileli, there is one question in the
I see.
Q&A.
Right. Dr. Mohammed Salemi is asking, what is your experience with reperfusion injury of the spinal cord after decompression, either anterior or posterior? And how do you manage it? Reperfusion injury.
C5 palsy you mentioned?
Reperfusion injury. Do you see any?
You asked about the C5 palsy?
No.
Reperfusion injury.
Reperfusion.
By the decompression.
Oh, sorry, I don't have any reperfusion injury. Yeah, in a meeting, spinal meeting, I think I've seen the reperfusion injury. Actually, there is no such a case in my series.
Yeah. Same is for me, actually. I didn't see any, but there are some descriptions on that in the literature, as you know.
I'm afraid that I think that is in reperfusion injury or just the spinal cord injury itself. I think I personally I doubt it.
Okay.
That is not the case of the reperfusion, but I think spinal cord injury. Even a slight impaction may bring a spinal cord injury from those cases, I think.
Okay. I will try to make a small summary of your talk as well. And then I think, as you have mentioned nicely, if the OPLL is in shorter levels, 1 or 2 levels, or you mentioned 1.5 level, then an anterior surgery is a good option. However, if it is more than 2 levels, a posterior laminoplasty should better be done, although there are some papers telling laminectomy plus fusion is another option. Another thing is that key line negative patients do not respond in posterior surgery very well. They should better go anterior surgeries. And to avoid complications like CSF leakage, floating technique may be preferred. And good planning and good fusion should be done if you are making a ventral surgery. But if you are making a posterior surgery, it depends on your preference as surgeon, whether unilateral laminoplasty or open door midline laminoplasty should be done. Any additions to my comments, Dr. Hida? Do you
Yeah,
have?
thank you. You explained my presentation very well. Thank you very much.
Thank you, Professor Hida. It was
Thank
great
you.
talk. Now I